Hey, good afternoon, everyone. Thank you so much for coming to this Institute for Addiction Science Distinguished Speaker Seminars series. I'm Adam Leventhal, so I direct the Institute for Addiction Science. And just a little background about our institute, if you don't know, we are an interdisciplinary unit here at USC. Our goal is to create collaborative research programs, education programs, and community engagement programs. And so part of our mission is trying to get experts out here who are leading experts to disseminate what the evidence says on key topics. So we're really pleased to have Dr. Glass here. I'm going to pass it over to my colleague, Dr. Hans O, and Hans will introduce Dr. Glass.
Hi, everyone. My name is Hans O. I'm an assistant professor at the School of Social Work, and I have the distinct honor of introducing our guest speaker today. This is Dr. Joe Glass. He is an associate investigator at Kaiser Permanente, Washington Health Research Institute. Before that, he was an assistant professor at the University of Wisconsin-Madison School of Social Work. Dr. Glass seeks to expand the reach of effective healthcare interventions for unhealthy alcohol and drug use. Broadly, his work centers around implementation science, evidence-based treatments in healthcare settings, referral systems, as well as the social determinants of health. And Dr. Glass also draws extensive practice experience being a social worker, a psychiatric social worker at the VA and Arbor healthcare system. And he has also some grants from the NIH, and I'm sure he'll talk a lot about that. But he's also a very dear friend of mine and a really great guy. So please help me welcome Dr. Joe Glass to the Institute.
Cool. Well, good morning, afternoon, I guess, and happy Friday. Thanks so much for coming here. I know that there's a lot of other really cool things you could be doing, and it's good to see people interested in addiction science. So, it's a really exciting day for me. Thanks, Dr. Leventhal and Dr. O for the very kind introductions, and I appreciate and thank the Institute's administrative team for arranging such a nice visit so far. And I'm really deeply honored to contribute to your distinguished speaker series. Let's see. Okay, make sure the slides are moving. There they are. Okay. So yeah, I'd like to really acknowledge that everything that I present today would not have been possible without the generosity of many, many people. And I highlight a few of these people on this slide. There are way too many to list, though. And I just want to thank them for their and provide, my sincere gratitude for their time, support, and collaboration, and especially for making work fun and productive. And I also want to particularly express thanks to Dr. Hans O here for putting me in touch with the USC Institute for Addiction Science. And also for his countless creative contributions to our work together. We published together and submitted some grant proposals and many more to come. Thank you. Today I'll present to you my interest in health services research and link my clinical background and also research experiences to that. I'll describe 2 ongoing randomized control trials, and I'd be happy to field questions at the end. And so here's kind of an overview of what I'll be talking about today. Okay, so I trained as a psychiatric social worker and later as a health services researcher, and I've been very interested in the problem of what is called in the field unmet treatment need. So in particular, substance use disorders, they're among the greatest causes of disability and death in the US, but treatments can be effective. But only 10% of people, and even less depending on the estimates, only 10 people with substance use disorder receive treatment in a given year. So there's a lot of work to be done there. And to just summarize the state of the science, very few people receive addiction treatment, and our field does not yet know how to meaningfully change this. So we've come a very long way, particularly over the past decade and the past few years. There's a lot of work that's really working on this aggressively in the field. but many challenges and opportunities lie ahead. So to begin tackling this problem, I think, this is a really older study, but we really need to appreciate that there are countless service sectors that people show up to with substance use disorders. And by substance use disorders, I mean addiction to alcohol or drugs. And so this chart here is from an older but seminal study that mapped out where people with unhealthy alcohol use or alcohol problems showed up in a very large county system in California. And so, what we see is that just a fraction of people with alcohol use are showing up to alcohol treatment. That's a tiny proportion of the pie of where people show up. Most people are actually showing up to other service sectors like primary care, criminal justice systems, and so on. So one way that I think about this is when I was a clinical social worker in the VA healthcare system, I worked in a large psychiatry service. And, me and my colleagues were experts in the treatment of alcohol and drugs. But we were only really ever seeing a very small piece of the puzzle here. So in an ideal world, to reach the most people with substance use disorders, you would be embedding addiction treatment professionals across all systems in a county. Okay, so one model that's been touted as having the potential to be implemented broadly across service sectors is called Screening, Brief Intervention, and Referral to Treatment, or SBIRT. Have folks heard about this? Maybe some nods. Okay, some folks have. Yeah, so what it is, it can be described as a comprehensive integrated public health approach to delivering early intervention services, prevention services, and treatment for alcohol and drug use. So it's very widely recommended by the medical community, by task forces, and by various administrations in the U.S. And it's got a lot of components that are each tailored to first identifying people with unhealthy alcohol or drug use, assessing them. For people with with low risk problems, there's not a lot of interventions indicated for that other than, hey, good job. But people with moderate problems, there's really what's indicated are brief interventions, which can be provided, sometimes in 10 or fewer minutes. But for people with alcohol use disorder, particularly the moderate or severe alcohol use disorders, what's indicated is a referral to treatment. And so just to have folks connect with treatment specialists who work with addiction. And no matter which pathway you follow on, it's always good to provide follow-up and support. So for SBIRT, for this program to be truly comprehensive, we need all components to be effective, and we need them to be implemented across service sectors, and we need them to be well utilized. And so some health systems like the Department of Veterans Affairs, they actually have a very good implementation of this model, but there are many opportunities for improvement. A little while ago, we conducted a study analyzing the National Survey on Drug Use and Health data. And according to that data, in general, what we found is that few people are receiving these services. So, across the U.S., most people report that they are being asked about their substance use. And this study was particularly on alcohol use. Most people are being asked about their alcohol use, but when a brief intervention is indicated, like when they actually, struggle with issues, so like just a small fraction are actually provided a brief intervention or advised to cut back. And also when people have severe problems, when a referral to treatment is indicated, few people are even offered information about treatment. So, obviously like a long way to go here. A more recent study by Mintz and colleagues essentially replicated the exact same analyses that we did with newer data from 2015 through 2019. And they found the exact same thing. The rates were not changed at all. So still a long way to go here. Okay, so SBIRT, great comprehensive program, not utilized very often. Okay, so SBIRT has to be utilized, but it also has to be effective to work, right? To make a population health impact. So on the topic of effectiveness, me and my colleagues began to notice that there were hundreds of studies on brief alcohol interventions and brief substance use interventions. It's a really rigorously studied topic, and they're effective for certain populations, particularly people with mild substance use problems. But what we noticed is that, kind of anecdotally, we noticed that these studies weren't really reporting on how effective is the referral to treatment components of SBIRT. So RT of SBIRT means referral to specialty treatment among people with moderate to severe problems. So we therefore undertook a meta-analysis to, see, well, really how effective is this referral to treatment component of SBIRT. And what we found is, combing through hundreds of studies, only 13 studies had actually evaluated the impact of SBIRT on referral to treatment. So how well is the referral to treatment component work? How well is it working? Do people actually go to treatment when you refer them? So these 13 studies did look at that question. They looked to see, are people receiving follow-up treatment services after their brief intervention? And you can kind of look right away, on these studies, only one of them had positive effects. And these studies were conducted in multiple settings. Our review was limited to medical settings, and most of the studies were in emergency departments or primary care, some in inpatient units, and another one in kind of cross settings. So most of these studies did not have significant findings. We also formally meta-analyzed the data, and here's a forest plot from the meta-analysis, which just looks at the aggregate intervention effect across studies. Maybe the studies were too small to find an effect. So maybe if we look at all the data together, you could potentially have statistical power to find an effect that's actually there. And what we found is actually, no, the aggregate intervention effect, looking across all studies, the risk ratio includes the value of 1, meaning, the findings were null. So, therefore, really, and I guess one more thing on that. I mean, we also did a ton of subgroup analyses on the different studies. We added additional studies that didn't quite meet our inclusion criteria, and the findings were still null. So what we found is that brief interventions were not efficacious in linking patients to specialty substance use treatment services. Kind of as a side note, this is a great example that researchers should always publish their null findings. This null meta-analysis actually had a very meaningful impact on our field of addiction treatment. It stirred a lot of commotion. Really what it said was calling the RT of SBIRT evidence base, was inaccurate. So, what do we do about it? Do we stop doing SBIRT? No, I don't think we should do that. It's a great comprehensive program. There's a ton of momentum there. It's really what service systems are using to address alcohol and drugs. I think it's a great model, but we need to spend more resources on investigating, what are effective ways to refer people, link people to treatment when it's indicated for them. Also, instead of solely relying on referral to treatment, what can we do to embed addiction treatment professionals or people with those expertise into systems where alcohol and drug use are identified? So instead of solely relying on sending people to specialists, can we also just treat the substance use right away where people show up? Okay, so that kind of leads to, building on all that work. I have proposed a 3-part research agenda for the field, in which includes these things. So I think we need to develop the evidence base on how to deliver effective treatments for substance use or wherever people seek care, not just, in addiction specialty treatment settings. We need to improve people's success at obtaining treatment whenever they seek it. Most people who are interested in substance use treatment actually try, but then aren't able to obtain it. And then third, we really need to address social determinants of health to improve engagement in substance use care. What we find is many people, report very practical barriers to care, barriers to receiving substance use care, things like being able to transport themselves to appointments, being able to take time off work, worrying about things like childcare, and so forth, payment for services. So we cannot solve this problem without addressing social determinants. Okay, so now to switch gears a little bit, what I want to do is present, I want to present two randomized controlled trials today. And the first study addresses the first bullet on this slide. How can we deliver evidence-based treatments for substance use disorders wherever people seek care? So the trial is called the DIGITS trial. It focuses on digital therapeutics for substance use disorder. And I define digital therapeutics as health apps or websites that serve as adjuncts to treatment. So, not really something that can be used on their own and just load it off the App Store and use at your house. I'm referring to apps that can actually help professionals provide more comprehensive substance use care. So we have completed the fielding of this trial. We've begun to submit our findings for publication. We have not yet completed analyses of the primary outcome data, so I won't share that with you today. But I will tell you about the trial, and I'll share some of our qualitative findings. So the DIGITS trial was a factorial randomized control trial evaluating the implementation, effectiveness, costs, and sustainment of digital therapeutics for substance use disorder in primary care, a setting where most people show 80% of the U.S. population visits primary care in a given year. So I'd like to acknowledge funding from the U.S. National Institute on Drug Abuse, as well as concurrent support from the National Institute on Alcohol Abuse and Alcoholism for funding this work. I'd also like to disclose that Pear Therapeutics, the maker of the app that we used in the trial, they donated prescriptions for the apps during a small pilot that preceded the trial. So we've received some in-kind contributions for our work. Some other background motivating the study is that actually in primary care practices, screening for substance use, alcohol and drug use is recommended. Most primary care practices do it. As we saw on the slide earlier, 70% of people report being asked about their alcohol problems, for instance. So these primary care practices identify vast numbers of people who could benefit from treatment. However, they're unable to provide effective treatments to these individuals because they don't have the capacity. Several effectiveness trials have shown that digital therapeutics are an effective adjunct to care by a clinician. So if they can be implemented in primary care settings, they could potentially increase the number of people who receive treatment. So definitely worth of a trial. So the DIGITS trial studied the implementation of Reset and Reset-O, which are prescription digital therapeutics. They're actually authorized by the U.S. Food and Drug Administration, have a labeled claim for the treatment of substance use disorder, which is pretty unique. And they're designed, Reset is designed for substance use disorder in general. Reset-O is designed for treatment of opioid use disorder in combination with medication. And these apps, they're implemented as smartphone apps. They have equivalent therapeutic content as what's called the therapeutic educational system, which had been validated as being effective in 4 randomized control trials. The way that they work is they have cognitive behavioral therapy learning modules. They have what's called fluency training, which is essentially quizzes to make sure that you understand the content. And they also implement contingency management, which is essentially motivational incentives or gift card incentives for positive health behaviors. And in fact, like contingency, cognitive behavioral therapy and contingency management are really the effective psychosocial treatments for substance use disorders. So a pretty robust intervention package. Okay, so, really what the research gap is, and also the practical challenge of doing research on this topic is we already, before we started the trial, we knew that primary care practices find it really difficult to adopt digital interventions. And when they do, and when they're offered to patients, patients seldom use them consistently. So they start to use them and then they stop after some time before they achieve clinical benefit. So those were kind of part of the problems that we needed to solve. And I want to be really clear that I do trust the effectiveness and efficacy data speaking to treatment apps. You know, they seem to work. But nearly all the studies are done in kind of researcher-based settings. They do not emulate naturalistic conditions of primary care or other healthcare places that have a lot of complexity to them. So they're not really conducted in real-world settings. So some of the challenges are digital interventions don't fit traditional care pathways. They're kind of different from what clinicians are used to doing. These systems that clinicians work in, typically, healthcare is, kind of low resourced right now. There's a lot of challenges there. There could be financial challenges in terms of affording these or technology resources that are required, like Wi-Fi access in the clinics that might not be there for all systems. Most clinicians don't want to touch software that is outside of their electronic health record because it's just another thing they have to do. I've been there. Also, I mentioned the issues with patient engagement with apps, but also there's the issue about digital health literacy. Obtaining or kind of engaging with an app to get better is something that's new to us as people as well. So, there's many other problems that I could go into, but those were kind of the main ones that we had to tackle. So yeah, a lot of scary issues to contend with, but the good news is that these are major challenges that can be addressed with implementation science. So which you likely heard about, which is defined as the study of strategies to improve the adoption, implementation, and sustainment of evidence-based interventions in clinical and community settings. So the research question of the DIGITS trial was, can practice facilitation and health coaching implementation strategies optimize the use and impact of digital therapeutics for substance use disorder among primary care patients in an integrated healthcare system? So we did this trial in the Kaiser Permanente, Washington's healthcare system, specifically in the Washington state region. This is a large healthcare system that serves people covered by private insurance, Medicare, and Medicaid. And an important aspect of the system is that behavioral health clinicians were embedded in primary care clinics, and we use those individuals as a venue for offering the digital therapeutic to patients. Okay, on this slide, this is what you call an implementation research logic model. This is for the DIGITS trial. So the determinants box here, the determinants are really barriers and facilitators to the issue that you're addressing. A lot of the barriers that we needed to address were, like I mentioned, it's a novel intervention modality. Clinicians aren't used to it. Patients often don't engage in digital, apps for health. And primary care teams are feeling overburdened already. They are doing lots of new initiatives all the time. To address these, we applied 3 implementation strategies. So one of the approaches that we used is we offered training to clinicians to familiarize them with the intervention, and we made an implementation toolkit that really helped simplify the provision of these apps to patients. The health coaching strategy provided a credentialed medical assistant who basically outreach to patients to build trust with them and provide supportive accountability. So to kind of check in with them, hey, are you using the app to try to promote engagement? The practice facilitation strategy, practice facilitation is an implementation strategy that provides a really well-trained person who goes into the clinics, works with clinicians within a supportive relationship to overcome workflow challenges, to really administering an intervention within their context. So we thought that these implementation strategies would improve digital therapeutic engagement among patients, the health coaching would, and that we thought that practice facilitation in particular would increase adoption of the digital therapeutic by clinicians. So this was an implementation trial. So the primary outcomes we're looking at reach of the digital therapeutic into the patient population. Can we reach more patients with it? Is it used with good fidelity? So are patients using it consistent with clinical recommendations? And can health systems sustain the implementation of the intervention after research funding is scaled back? And secondary outcomes focused on substance use reductions in the patient population, and then population level cost effectiveness. So this trial's design was a cluster randomized trial, meaning that the unit of randomization was primary care clinics. So we recruited primary care clinics and then randomized the way in which they implemented the apps. So we used the 2x2 factorial design. So we randomized, all clinics got, the basic implementation support to help them just start offering the apps. But half of clinics were assigned to health coaching and half were assigned to practice facilitation. And with the 2x2 factorial, it means that the 22 enrolled primary care clinics, there are actually 4 different approaches that they could have implemented with. So it's basically like 5 or 6 implemented with each of these conditions. This allows you to compare not only the main effects of practice facilitation and the main effects of health coaching, but also the interactions between the two. Okay, so the study had 3 phases, a preparation phase, an implementation phase, and a sustainment phase. The preparation phase included design work to really develop the implementation model, to develop the workflows. After we did that, we piloted the implementation. The implementation phase was really operationalized as the randomized control trial. And the sustainment phases were, again, we pulled back implementation resources and kind of watched to see, does the health system continue to use this? Okay, so a spoiler alert is that the digital therapeutic vendor that made Reset and Reset-O, they went bankrupt actually during really early in the sustainment phase, and so we had to end the trial early. Luckily, it was after the RCT phase, so we were able to, analyze the RCT data. But unfortunately, we weren't able to do some of the things that we wanted to do in the sustainment phase. So that's a good lesson learned there. To really, as you partner with these, if you do these trials yourself with digital therapeutics, definitely work with the companies to inspect the financials and pay good attention to like the policy environment, the reimbursement environment, and stuff like that. So, okay, and this just depicts where we applied those implementation strategies. We again, we piloted them, and then they existed during the RCT, and the standard implementation strategy was going to continue throughout the sustainment phase, but of course that was ended early. Okay, so some of the qualitative findings, I summarized as lessons learned. Some of the facilitators to successful implementation is that actually patients really liked engaging with a health coach, not just getting an app, but actually having somebody, who would follow them, work with them, figure out, how is it going? What kind of content are you engaging with? And reminding them to use it. So some patients engaged very well with the health coach, but others actually were not even interested in talking with the health coach. They kind of said, I really want to just do this on my own. And I don't want to talk to yet another person. So that was also it was a facilitator, but also not a perfect uptake there. Another facilitator is the practice facilitators. I mean, these are really kind of engaging people, charismatic. They're very good at engaging with clinicians in the healthcare system, and they actually fostered enthusiasm among the clinicians who they were working with. some of the barriers was that, actually this trial was fielded during COVID, and like all other healthcare systems, there was, a lot of problems retaining staff. There were staffing shortages. There was turnover of staff who we would, train. They begin using and they, kind of leave the system. And so those were major barriers to implementation. When we first implemented, we wanted all the clinicians to make sure that they followed up with patients like monthly, that they would have visits with the patients after they prescribed the apps. But what we found is that, kind of related to the staffing shortages, sometimes it was difficult to provide that follow-up to patients. The clinicians found that it was difficult to provide that follow-up to patients consistently, and sometimes the patients didn't even want it. Like they just, again, just wanted to use the app on their own. So we ended up dropping the requirement for that follow-up visit. We made adaptations based on what we learned as the trial was ongoing. Clinicians also complained that it took way too many steps to prescribe the apps, and that it was hard to remember website tasks. Like they had to log on to this dashboard and create the prescription for the patient, give the information about how to activate the app to patients. They said it was hard to remember that. So we made adaptations again throughout the trial. The practice facilitators, they were able to foster enthusiasm to the extent that they trained additional clinicians who we didn't even initially intend to train to prescribe the apps, and to really address some of these issues around clinicians having difficulty with prescribing the app. We then offered clinicians the option to actually kind of delegate those responsibilities to somebody else. So those were some of the adaptations that we made during the trial, and that we're actually now have the opportunity to study using interrupted time series methods, the impact of these adaptations as the trial unfolded. Okay, so key recommendations. So first of all, the field needs so many more studies like this one. It's not going to be an easy kind of nut to crack, so to speak. So, if you're interested in digital therapeutics and want to do an implementation study, they're very fundable and very needed right now. If you embark on that, what I'll say is just a few tips is you want to automate as many workflow processes as possible. So reduce burden on the clinicians as much as you can. Some of these app vendors offer EHR integration, meaning that there's kind of two-way data communication between the healthcare system's electronic health record and the app vendors' information systems. A lot of the vendors actually offer, like, for instance, peer support services. So instead of using a medical assistant health coach, the app vendors will offer peer specialists to connect with patients themselves to solve the technical difficulties, to help boost engagement, and so forth. So I would say, that would be another nice resource to use. And then also, whatever you can do to have the only thing that you ask a clinician in the health system to do is just click a button to refer patients to use the app and then have somebody else do everything else. That's going to maximize implementation. The other thing is, like, turnover in healthcare is not a new thing. It just happened to be way worse during COVID. But regardless, you need to really proactively address that. If you have clinical champions, like people who are like using apps, definitely lean into that. Use that as much as possible, but have a few extra people on, kind of in the dugout or whatever, ready to backfill these clinical champions who might leave the health system. And another really key recommendation is to, in your trial, try to build in ways to monitor the equitable distribution of these apps across health disparity populations. So in particular, you can think about many factors like across rural versus urban areas. Obviously, things like Wi-Fi access everywhere in urban areas, rural areas, not as much. And then also across race and ethnicity, there can be, there's definitely evidence that apps are acceptable in very diverse populations, but it doesn't always mean that the apps are tailored to populations. So, for instance, some apps are only available in English, right? Some apps, might use kind of like, majority, what do you want to call it? Just, language and, kind of the cognitive behavioral modules are essentially just reading a ton of content, and that app content really should be tailored, as well as age. So as we know, like younger generations are definitely more into engaging with technology. Okay, so that was the Digits trial. Returning back to this three-part research agenda that I proposed, the next study, which is also ongoing, addresses these two bullets. One is to improve people's success at obtaining treatment wherever they seek it, and then also to address social determinants of health to improve engagement in substance use care. So this trial is called the Addressing Barriers to Care for Substance Use Disorder trial, or the ABC-SUD trial. So kind of a little background, recently I had the opportunity to collaborate with teams from multiple institutions to obtain funding from the National Institute on Drug Abuse for a National Center of Excellence on Implementation Science. It's called the Center for Dissemination and Implementation at Stanford. That's the prime site. It was led out of Stanford. And within the center, there's 4 trials. So I'm leading one of the 4 trials. It's called the ABC trial. And each of the trials is a 5-year study. And each trial is led by an investigator at a different institution. So for instance, like myself, at Kaiser Permanente leads this trial. So the center, I'll also say that this center also has an educational mission. They have a fellowship program. They're actively recruiting right now. So if you have a PhD or will soon be post-PhD, definitely get in contact if you want me to send you a flyer and answer questions about the fellowship. One other really cool thing about doing a trial within a center is that in this study, while the trials are all independent and studying different topics, we're all using consistent measures across the studies. So when the trials are done, we're going to be able to aggregate these measures and look at implementation constructs, and analyze them across studies. Which will be pretty cool. Again, I'd like to acknowledge funding from NIDA for this trial. Here's a research team that's working with me on the trial. It includes colleagues who I've worked with for a long time at Kaiser Permanente, as well as folks from Stanford University. It also includes clinicians who work in the care delivery system. Okay, so the ABC SUD trial is testing a care navigation intervention. So what is care navigation? It's a psychosocial intervention, often delivered by lay health workers, peer specialists, or mental health professionals, that really seeks to facilitate timely access to care by working with patients to identify the barriers to care that they experience, and helping them navigate a complex healthcare system. So in our study, care navigation is a 7-week intervention. It's conducted by a master's licensed clinician. It includes these 13 core functions listed on the slide. But in short, care navigation, it uses motivational interviewing as the base of the intervention. And on top of that, the care navigator works with a patient to foster trust in the healthcare system, to assess the barriers that they experience to substance use treatment, to identify practical resources to help them address barriers to care, and problem solve around addressing these barriers. So this study is also being conducted in the same health system in Washington State, and we're testing the effectiveness of care navigation within what's called a mental health treatment access center. And this is a place where patients call when they're seeking substance use care. It's staffed by 40 care coordinators who assess patients' mental health or substance use problems, and then refers them to an appropriate treatment agency where they could call and then seek treatment. And in this health system, while the health system provides comprehensive primary care, they don't provide much addiction treatment internally. So really what these care coordinators do is they link patients to different treatment organizations outside of Kaiser Permanente that exist across Washington State. And they serve about 400 patients with substance use disorder per year. and many, many others with other mental health concerns. So the aims of the study to evaluate the effectiveness of the substance use care navigation intervention within the Mental Health Treatment Access Center to see if it helps increase patient success at obtaining treatment and engaging in treatment after they call for help. Another aim is to generate information about how to optimally implement this intervention into other routine care settings. So we just don't want to understand only its effectiveness. We also want to generate, toolkits and other information that can help other places bring it into practice. Okay, so here's the implementation research logic model for the ABC trial. In the determinants box shows a few barriers that clinicians experience and some barriers that patients experience in regards to initiating substance use care. For example, some of the clinician difficulties is, they need to know how to, they need to know what care navigation is. They need to know how to refer patients to it. They need to learn how to work with a care navigator. So there's some knowledge needs. Again, these clinicians have many competing priorities in a healthcare system. Clinicians are always working on new initiatives, and there's kind of change fatigue and also process fatigue. They have to learn different workflows for all the different interventions that they're taking on. So those are some clinician level barriers that we sought to address. And then for patients, the complexity of the health system is, healthcare is pretty complex. There's enormous complexities. Think about how difficult it is sometimes to obtain any treatment. And then think about how difficult it can be to obtain a type of treatment that requires going somewhere else, that requires insurance authorizations and so forth. So we're seeking to address that. There's also many negative perceptions about substance use treatment. And then, motivation to seek treatment waxes and wanes. It kind of comes and goes for people all the time. So we are using implementation strategies to address the barriers that clinicians experience. And we're using care navigation to address the barriers that patients experience. For instance, we think that training care coordinators to offer care navigation. We think that providing the care navigators themselves with clinical supervision and simplifying the process of referring patients to care navigation will increase referrals to care navigation, so it's used more. Will increase clinicians' competence in conducting these interventions. The training will help decrease the complexity. And we also use this implementation strategy that we call data and stories, where we provide basically clinicians with feedback every month about what are patients saying about the intervention and how many patients are they referring and how many people are they missing when they make referrals. Whereas care navigation, I already explained, and essentially we're trying to boost motivation and reduce barriers to care for patients. So this study, it's also an implementation trial and an effectiveness trial, but the primary outcomes actually are the effectiveness outcomes. So we're primarily devoting the resources in the study to see if care navigation implemented in the setting boosts rates of treatment initiation and engagement among patients and decreases substance use. And then also for the implementation aim, we want to see how many patients within the setting does this care navigation reach? Is it delivered with fidelity? And how much does it cost for healthcare system? Okay, so this study also has preparation, implementation, and sustainment phases. And this slide shows how the study activities and implementation strategies are grouped across phases or used across phases. Where we're at right now is we are in the design and piloting phase. We're still pretty early on. We've completed qualitative interviews with patients, and we're holding implementation meetings with clinicians and leaders of the healthcare system to design and establish the workflows to write intervention manuals and kind of to work out the kinks to make sure the intervention can be integrated smoothly. We just got ethical approval or IRB approval to start the pilot study. So we'll start that in a couple of weeks. And we will start rolling out care navigation to 4 care coordinators we'll be able to offer it to patients. Once we're done with that pilot, we'll roll out the implementation to the rest of the mental health treatment access center. So we'll randomize remaining clinicians, about 35 of them, to offer care navigation or not. So it's again, it's RCT randomized at the clinician level. Either a clinician will offer care navigation to patients, or the clinician will continue service as usual. So obviously, to get 35 or so or 40 clinicians to start offering care navigation to patients, they need to be trained. They need they work in the EHR to place referrals, and so we need to develop tools to do that. The care navigators themselves need clinical supervision to ensure that they're delivering motivational interviewing to fidelity, for instance. And I mentioned the performance feedback, the data and stories that's going to happen on an ongoing basis. As far as sustainment goes, once the RCT is done, I mean, the health system is very interested in this intervention. It's intuitively a good thing to do. So we'll, of course, their implementation decision will depend on how well the trial goes. But what we'll do is before the trial is done, we'll start working with them on implementation plans and sustainment planning. And then we'll see if it sticks. And so I think this is the last real content slide. So I mentioned that this study is one of 4 within a National Center of Excellence, and we're all administering the same measures as we conduct the study. And all of these measures have to do with what are the factors that affects implementation, how does the leadership at the health system site, how much do they support the implementation? There are many qualitative questions about how to tailor the intervention to the local context and to the patient population. We're also administering a stages of implementation completion instrument because there's evidence that shows the faster you get through the implementation stages, the more successful implementation is. We're doing a cost assessment, which involves multiple activities. And then some of the implementation outcomes are also the same across studies. And we also have study-specific measures that are unique to our study as well. Okay, so those were, that's an update on, some of my recent research on interventions for substance use disorder. And I wanted to kind of leave us with some challenges and opportunities ahead for us as a field to address, and that I'm really interested in addressing. So here's kind of a roadmap forward for that. So, for me, I'm very interested in collaborations with addiction researchers, with people with complementary expertise, and particularly in new collaborations with folks who work in safety net healthcare systems and other service sectors. That's really a passion of mine to do this work. And, for instance, federally qualified healthcare centers. So I'm absolutely always on the lookout for new colleagues. And some of the questions that I'm really interested in addressing are, how can we address social needs while caring for substance use outside of specialty treatment settings? So this study is a trial that shows an example of how you could address some social needs of patients to improve healthcare. But I think that addiction interventions, especially as they're implemented in non-specialist settings, we really need to infuse social needs interventions within, these other settings. And so, for instance, brief alcohol interventions in primary care settings are designed to be 5 to 10 minutes. If we start treating alcohol use mostly in primary care, we can't forget that the whole, one of the reasons that we send people to specialty treatment is because they struggle with so many social needs that it's hard for them. It's hard to treat substance use without addressing social needs. And so as we kind of take these interventions outside of specialty treatment and put them into primary care and other non-specialty settings, how can we still address social determinants of health? Because I think that would be a huge loss to ignore that. Kind of another focus is which service sectors can we readily implement low intensity substance use interventions in? Again, it's not just primary care. There's a lot of other social service sectors where people show up. And also, can our current interventions be effective in those settings? And what kind of ways do you need to tailor them to be effective? And then last, how can we engage people who might benefit from care but do not currently perceive a need for treatment? So, one of the biggest barriers to people receiving treatment is actually that they don't think that they need it, or it's not appealing to them. So, how can we change that? So again, definitely looking for collaborations, and that's what I've got. So thank you so much. Here's my contact info. Please feel free to reach out. Thank you for the opportunity to present to you today. Been nice to see some new faces, to be back in an academic environment. So thanks for the opportunity, and please ask questions.
Any questions for Dr. Notes?
Don't be shy.
I have a question.
Yes.
When you're talking about your meta-analysis, I know a lot of brief intervention studies will exclude people with DSM dependence.
Yes.
I'm curious if that's what you saw and how much you think addressing that dichotomy is important for people.
That's a really darn good question. Yeah. So actually, that's a really good question, and I can tell that you're really familiar with this literature. Yeah. So I mentioned that there's hundreds of studies. There have been hundreds of studies on brief interventions in the past, and it's very true. Like, it's brief interventions are conceptualized as something that for somebody with low severity problems, and so most of those hundreds of studies they probably didn't evaluate receipt of alcohol treatment services because the population may not have had severe problems, and you wouldn't, refer somebody with low severity problems, let's say somebody who, has binge drinking on the weekend, you probably wouldn't refer them to specialty treatment. Yeah. So actually, yeah, like a lot of those studies excluded that population. We did look, one of the things we did is that was kind of one of the stratification factors that we addressed in the meta-analysis, is we grouped studies based on, and sorry, this is a really old slide. I think this language is stigmatizing. I would say people with alcohol dependence. So yeah, but anyhow, we stratified the sample based on the severity of people with the severity of people's unhealthy alcohol use. And I think that kind of answered your question, but did you have another one? Okay.
Thank you.
Yeah, no, that was really good. Other questions?
Yeah, so there's a couple online
Okay.
to our Zoom audience. Hopefully I'll say this loud. So one of the questions was about research to help with like medication adherence. And one of our viewers was really interested in kind of your thoughts about, facilitating that.
Yeah.
You spoke a lot about the behavioral and the counseling interventions, which are critical, right?
Absolutely.
Yeah. So anyway, I'll let you field that one.
Yeah. So just in general, interventions to improve the uptake of medications. Yeah, I mean, so that's another difficult issue to address. And actually, we recently, one of my colleagues led, and I participated in a large multi-site study of really trying to, that focused on, how can you prescribe opioid use disorder medication with buprenorphine and so forth in primary care settings, and how can you make those prescriptions engaging. I would say that, and in that study, the interventionist was a nurse care manager that was able to provide like a lot of follow-up support to patients who, had the time to get to know them, and who worked with the prescribing physician really to the nurses were really the front line to understand patient needs understand difficulties with medications, not just kind of personal difficulties, but also like, difficulties with getting prescriptions and so forth. I think that like when you talk about, adherence, I'm a social worker, so that's my bias. The first thing that comes to my mind is just what is the relationship that you have with a patient? Are you exploring the difficulties that and the concerns that they might have with their medication? Kind of like the patient's philosophy, but also, what are the barriers that patients are experiencing? So yeah, I think that's a really, really important question to address. Medications are certainly interventions that you want to take as prescribed, and they typically don't work very well if you don't. So yeah, really important question. And again, as a social worker, I think about what is the person experiences, how can you assess what are the reasons that they're not taking them? So yeah, if there's any follow-up on that question, I'd love to talk more about it.
Yeah, that's Amy Rohr. Thank you, Amy.
Thanks.
Hopefully I spelled your name correctly. We have time for one or two more questions.
Yeah, so in the second thing you talked about planning for a lot of these like implementation science outcomes, the looking at fidelity and reading and all this. Are you, maybe I missed, but are you planning on looking at like the patient level outcomes as well?
Yeah. Let's see. So maybe I'll say the most obvious one, and then you can dig more. The patient outcomes are initiation and treatment. Does the patient actually follow through on the treatment referral? Do they start attending treatment? And for how long do they engage in treatment? We also are looking at reduction in substance use. So those are the two. From the implementation perspective, we're assessing way more stuff. Like I showed that big list. All those are really clinician healthcare system focused.
Any other questions in the room? Sure. Okay. So see what the best. Maybe just someone asked if you could just flesh out a little bit more, because we just have a couple minutes left. What practice facilitators are?
Oh yeah, sure. That's cool. So let me pull up another supplemental slide on that.
Come prepared.
Kind of totally breezed through that, but I just ruined my screen share. Okay, so I'm not going to use the slide.
That's all right.
Exactly. So practice facilitation. So it's an implementation strategy. There's multiple kind of versions of it. It is, and the one that we use in this study was operationalized by the VA. Actually, in Little Rock, there's I would Google Joanne Kirchner practice facilitation VA, and you'll find the manual. It's really practice facilitation. The idea is that you find a very a good people person who develops a relationship with clinicians in the care venue. And really what they do is within a context of a supportive relationship, they really learn they can fill in educational gaps about the intervention, but really what a focus is on is within that healthcare setting, what are all the reasons why is it going to be difficult to deliver this intervention? And what are some ways we can problem solve those difficulties? There's also an emphasis on what's called audit and feedback, but that is from week to week or month to month, however often you meet, the practice facilitator meets with the clinicians. You look at data and you develop these performance goals that are database. So, you'll say, well, for instance, if a performance goal is to increase the number of digital therapeutic prescriptions, what you need to do is track data on digital therapeutic prescriptions and month to month, monitor if they're going up and down. And if they're not going up, work with the clinicians to problem solve. Well, what can we do to help make those prescriptions go up? Try out, an approach to increasing prescriptions, and then re-review the data in the next month and have conversations about you know, did that work? Yes or no? If not, why not? What else can we do? So, yeah, so that's an example, but yeah, definitely Google VA practice facilitation, Joanne Kirchner.
Awesome.
Yeah.
Yeah, thank you so much,
Yeah.
Dr. Glass. That was a
Thank you.
great talk. Thank you so much. So, I am just going to tell everybody, please come back. So on April 17th, we're pleased to have Stephen Murray, who is an overdose researcher, the harm reduction program manager, and the director of the Massachusetts Overdose Prevention Helpline at Boston Medical Center. His talk title is Overdose Prevention, Detection and Response, and Navigating the Intersections of Education, Advocacy, Implementation, and Partnership. So April 17th, come back. And those who are here live, we have lunch. And so you have an opportunity to talk to Dr. Glass, get to know your colleagues, and yeah, enjoy each other's company. So yeah, thanks again. Yeah, okay.